Hey guys, welcome back to another lecture. This one is on bites and stings, and we're also going to cover allergic reactions because they can be caused by stings. So let me add that here. Allergic reactions and anaphylaxis, which we will learn really just means it's a very bad anaphylaxis, really bad allergic reaction. So let's talk about bites and stings. One of the more common things that'll sting you are arthropods. It's a fancy name for bugs. Insects, spiders, scorpions. Reptiles like pit vipers and coral snakes. Both are snakes, of course. And then venomous marine life. As far as bite and sting deaths, which are actually fairly rare, about 50% are from insects, 30% are from snakes, 14% from spiders, and 6% other. So Hymenoptera. This is a fancy name for the class of all things that are yellow, black, and stingy, as well as ants. So bees, wasps, hornets, yellow jackets, and ants. There are only about 25 deaths per year in the United States. About honeybees, it's about 50%, and yellow jackets and other wasps are about 50%. The problem here really is the allergic reaction and anaphylaxis. This is really what's killing people. Rarely will you have effects from the amount of venom. You get just a really small amount of venom from the bee sting, and the problem with it is more so the body's reaction and less so the actual venom. However, there are cases where patients are stung hundreds or thousands of times, and the venom actually does cause the patient to die. So with any kind of bite or sting, although really more so with the bee stings, the Hymenoptera stings, you get a sharp burning pain, you get itching, edema, remember that's just swelling. You may have extensive reactions that involve swelling of the entire extremity, and then tongue or throat stings may cause airway loss. And I actually had a friend in high school, we were out playing basketball, and she swallowed a bee as we were playing, and it somehow stung her in the throat. She was really uncomfortable. I felt bad for her. But she didn't lose her airway. But it is possible to get stung in the throat or in the tongue. Oops. You can get systemic reactions as well. So systemic reactions I like to define as essentially having more than one system involved. And this is going to be true for any type of allergic reaction, not just a sting, but this is any kind of allergic reaction. So more than one system involved. So basically, if you have swelling that's distant from the sting site, you've probably got in a reaction that's going through your system, so you end up with swelling. If you were stung on the leg, for example, and the patient's now complaining of trouble breathing, so you have some hives on the leg where they were stung, and then you also have the respiratory system involved, so that gives you two systems involved. Urticaria and swelling, flushing, anything that, especially distant from the sting site. If the reaction is progressing very quickly, so if you get there and there's a very small area that's involved, and then maybe 5 minutes later a whole extremity is involved, that's a pretty rapid progression, and so that kind of brings you past mild. That brings you more into the systemic type reaction. A severe systemic reaction, which we tend to call anaphylaxis, and I'm going to talk about that on the next slides. Anaphylaxis. It can cause laryngeal edema and upper airway obstruction, so your throat will actually swell closed. You can end up with severe bronchospasm and difficulty breathing and profound hypotension, so really, really low blood pressure. This is anaphylaxis. Other causes, medications, so patients can have anaphylactic reactions to medications. Food, the 8 most common offenders are peanuts, tree nuts, soy, wheat, dairy, eggs, fish, and shellfish. And then some plants can cause reactions as well. So what do? Well, you want to remove the stinger, and this and every textbook I have read says you should scrape with like a credit card or some kind of business card or something. If you happen to have a pair of tweezers, or you can just grab it and pull, that's okay too. The key is to get the stinger out quickly. you know, for test answers and such, use the scrape method that, you know, find a credit card or something. And that's probably honestly what you're more likely to have handy. And if you can't find one and you feel like you can grab the stinger with your fingers and get it, then go for it. The reason is that the glands that inject the venom continue to function after this, you know, the bee has basically flown off and left the stinger behind. And what you want to do is squeezing them is not really that big a deal. The issue is how long is the stinger in place. So you want to get the stinger out, and however you can do that will be functional. But again, test answer, you got to scrape the stinger out. Manage the airway. So really, you kind of got to do these at the same time. So hopefully you have a partner. Oxygen to maintain SATs above 94%. You can assist ventilations as needed. Shock position, you will use if anaphylaxis is truly present. Use the Epinephrine Auto-Injector. And don't just consider, but absolutely call for ALS backup. So epinephrine, I mentioned the EpiPen or the Epi Auto-Injector. EpiPen is a very common brand name, although a new one has just come out. The brand name is kind of escaping me, but it's actually fairly simple. You remove the cap and then it actually talks to you and tells you exactly what to do, so that's pretty cool. Regardless of the form, the drug is called epinephrine. You guys need to know this. So what does epinephrine do? Well, it dilates out the airways, it constricts the blood vessels, and it raises peripheral resistance via blood vessel constriction. It also helps the blood vessels be less leaky. And when we look at the reason for anaphylaxis, remember from our shock lecture, in anaphylaxis, you vasodilate, your blood vessels become leaky, and so you end up with a relative hypotension. So we want to give the epinephrine to help reverse this relative hypotension. And this is a picture of the EpiPen. They have redesigned them, I think, since this picture. They're now like blue and green or something. They're a little bit prettier. But the concept's the same. Basically, there's a needle in here. There's a cap here. You pop the cap off, put this end toward the patient, and then you push down, and the needle shoots out and injects the epinephrine. Oh, and your adult dose you can see here, and I would know this, is 0.3 milligrams. There's also an EpiPen Junior, and it's half of that. It's 0.15 milligrams. So be sure to learn your dosages as well. So when do we give it? Well, when we have an allergic reaction with respiratory compromise, rapid or labored breathing, chest or throat tightness, hoarseness, stridor, or wheezing, or hypoperfusion, so rapid weak pulse, altered level of consciousness, and a decreased blood pressure. Don't hesitate to use it. Contraindications, so really there are none for severe allergic reactions. If they have cardiac history, so, you know, like an old heart, just have in advanced age, I like to call an old heart, then be careful with that. If they have any kind of cardiac history, epinephrine is going to make your heart beat really fast. That's one of the side effects, I guess, but, you know, epinephrine is really just adrenaline. It's something our body produces naturally. So our body's used to that. It's what we get in the fight or flight response. So all of those same things that you'd get with the fight or flight, you're going to get with the epinephrine. Oh, here's your dosages. Adult 0.3 milligrams, pediatric 0.15 milligrams. So the procedure, expose and clean the site if possible, although you can actually inject like through blue jeans. It'll go through, but we prefer in our environment to expose and clean the site. Remove the safety cap, put it 90 degrees to the sun, to the skin, lateral thigh midway between the waist and the knee, and then push against the thigh. Hold until the medication's injected, which is for 10 seconds. And when we do the skill in class, I want you to actually count out loud to 10 seconds. The side effects, like I mentioned, rapid heart rate, pale skin, they'll probably get a headache. They may have some chest pain with it. They may feel nauseated or throw up. And they're likely to feel anxious as well. So precautions, this says oxygen first. Oxygen in with time. So make sure you get them on oxygen, but if they're really truly critical, really hypotensive, go with the EpiPen first. But don't skip on the oxygen, so make sure you're getting your patient oxygen. Monitor the vital signs following the use. You know, when we give Epi to patients at the ALS level, it's a drug we can give really every 3 to 5 minutes. It may be that you see an improvement initially, but that improvement may not hold out if it's a truly severe reaction. So make sure you have backup on the way. If they have a secondary EpiPen, have that ready to go. And depending on what your protocols say, you can either give it if they need it or call and ask permission from a doc on medical control to use a second dose if you need to.